Good evening and welcome. I'm Chris Parnell.
Reporting from Moscow.
Tbilisi.
Times Square.
May your dreams be your only boundaries in life.
Welcome to Living Well. I'm Rebecca Cullison, filling in for William Kinley. We're going to take a look at several important health issues today. First of all, we're going to talk about heart attacks. Dr. Jeff Mullins with Mid-South Family Medicine joins us today to tell us what to watch out for when it comes to a heart attack and when we need to go to the doctor. Welcome, Dr. Mullins. Thank you for being here today.
No problem. Thank you.
To get us started, just tell us a little bit about yourself and your practice.
I'm board-certified family medicine doctor, and I've been doing this for about 25 years now. I see a variety of patients in my practice. Over the years, I've gone from seeing just as many pediatric and adolescent cases as adult cases to mostly as an adult practice now. So I deal with an age group most commonly between the ages of 30 and I saw a couple the other day that were in their 90s. So in that range of patients is where we see the most often cardiovascular disease resulting in heart attack.
Absolutely. Well, tell us a little bit about what are those warning signs we need to look for with a heart attack?
Well, there's classic warning signs and then there's other signs. And the classic warning signs are what we call substernal, beneath the breastbone pain, oftentimes over to the left. This pain may radiate down to the arm or up into the neck. And it's interesting, the reason why we believe that happens is as the fetus develops, skeletal nerves, like to your arms and legs, basically develop at the same time the bones and the muscles do. So if your leg hurts, there's something going on in your leg. But viscera, like the heart or other internal organs, kind of hitchhike the nerves as other parts of the body develop. So you may have one person that has a heart attack, has very classic symptoms of chest pain on the left side. You may have another person who has no chest pain, but their arm hurts, or they have pain in their neck or their abdomen. So it's generally a significant pain, very sharp pain. It's one that is very difficult to ignore. This is usually accompanied by a pressure-like feeling. Some people have described it as an elephant sitting on my chest, and breaking out in a sweat, a lot of times with nausea. And then the one that almost always gets my attention with a patient is when they tell me they have a feeling of impending doom. They just know that something is horribly wrong. And a colleague of mine, his father had a heart attack recently, and his major complaint was he thought he was dying. Those are the easy ones because no one's going to sit at home thinking they're dying and not call 911. But there are some more subtle symptoms, and particularly in women. Women, sometimes as a clinician, women can be rather frustrating in pinning down whether they have heart disease. And I've diagnosed several women with active heart disease that needed immediate intervention that were having little, if any, chest pain. They were having some shortness of breath. They might have been feeling some pressure, but they really just felt unusually tired a lot. And whenever they exerted themselves, they seemed to get short of breath a lot more quickly. Particularly women over the age of 50, the signs may be more subtle, and that is, I think, one of the values of going to see a physician on at least a yearly basis, or at any time you feel like there's just something not right about how you're feeling, because that's how those cases were picked up rather than the classic get a call to 911 from home because my husband or my wife's having severe chest pain. But the classic ones, if we could just get people to focus on these, would be chest pain, often radiating into the left arm or neck, diaphoresis or sweating, nausea, and a feeling of impending doom. And if they have those type of symptoms, that's not a call to your physician to ask what to do. That's a 911 call to get an ambulance service. EMTs have things like nitroglycerin and oxygen and epinephrine on board. And if they can get to your home pretty quickly, a lot of times they save lives. Plus, they can do an EKG on site and be sending that to the emergency room where you're going to go, and the doctor there can already be appraised of what's going on with you so that they're ready to handle you when you come in. There's like in trauma, there's a magic hour that occurs from the onset of a heart attack to the time that intensive treatment is given. And if most patients can receive that treatment and intervention within that hour, their lives can be saved.
Absolutely.
But at the end of the day, the reason why this is such an important topic, 50% of people do not survive the first heart attack. So it has a 50% mortality rate. So I've had patients that were kind of lackadaisical about their diet and exercise and about watching their cholesterol and their blood pressure issues and these kind of things. And I almost get the feel that in their minds they feel like they're going to have an opportunity to have like a mild heart attack, and then maybe if that ever happens, they'll change their ways. Well, 50% of them won't make it past that. So preventing a heart attack is the best way to treat one.
Absolutely. And you mentioned how important it is to call 911. I know at the hospital many times we see people arrive by private vehicle, so calling 911 is so important.
Yeah, and you know, like everything else in medicine, there's no hard and fast rules.
Right.
If you live across the street from a hospital, I don't know that I would wait for an EMT to arrive there to get you to the emergency room. I think it's a fair question to ask when you call for an ambulance to come, how long is it going to be to get there? Because ambulance services, they don't have an infinite number of ambulances. And if they tell you we'll be there within the hour, it actually may be better for you to put the patient in the car and drive them there. But ideally, call 911, wait for the EMTs to get there, because they have the life-saving equipment that can make all the difference.
Right.
And for the most part, they'll get there in plenty of time.
You mentioned the substernal pain, and I know many times patients can think that's heartburn. What are the differences, and how do you know, is it heartburn or is it a heart attack?
Well, that's a great question. You really don't. And I always tell my patients I'd much rather you feel foolish after a trip to the emergency room and they told you that it was just really bad heartburn than a trip to the morgue or the funeral home because you made the wrong decision. So I think if you look at it that way, it's the other symptoms that go with it.
Right.
Shortness of breath, pressure in the chest, breaking out in a sweat, and again, that feeling of impending doom where you just know there's something horribly wrong. I've had real bad heartburn before, and I didn't have any of those other symptoms. I knew what it was and chewed up a couple of antacids and I was fine. Yeah, that's a great question. There are other things that can cause chest pain, some of them very serious too. So I think if you have severe chest pain, your best option is to treat it as if it's your heart. You're going to get treated more quickly and get to the hospital more quickly, and you'll be monitored as if you have a heart problem. If it turns out it's not, then it's not. It was a good day for you.
That's right, that's right. Just be thankful that it wasn't.
That's right.
Are there people who are more at risk for heart disease who need to be particularly cautious?
Absolutely. A lot of people worry about family history, but family history with heart attacks is not always as important. If your mother and father were very obese and they both smoked, both had diabetes, for example, that kind of thing, and they both had heart attacks in their 50s and 60s, but you're thin and fit and don't smoke and don't have diabetes, it's questionable as to how much the family history plays a role in that. So we focus on the things that we know matter, and one of the number one risk factors for heart attack is diabetes, and we're having some sort of an epidemic of that now. Your risk for having your second heart attack, if you're a pre-existing patient that's already had a heart attack, your risk of having a second heart attack is actually obviously pretty high because you've already had one. Your risk of having your first heart attack as a diabetic is the same as a heart patient having a second heart attack. So we consider diabetes to be a coronary artery risk equivalent, and so that's one of the highest risks you can have. Smoking definitely increases risk of heart attack, and because of the vasoconstrictive effects of nicotine, within 24 hours of your last cigarette, your risk of heart attack drops significantly because of the immediate effect of nicotine on the coronary arteries. High blood pressure significantly, particularly if it's not being treated correctly, significantly increases your risk. And then there's high cholesterol. And that's high cholesterol we'll talk about later, but it's kind of changed how we look at things. It's not as cut and dry as it used to be as far as who needs treatment and who doesn't. But cholesterol definitely plays a role.
Absolutely. Well, we're going to talk about some of those risk factors in just a minute. But right now it's time for a quick break. Up next, we're talking about cholesterol, what it is and why you need to watch your numbers. We'll be right back.
Okay, Josh, do your stuff.
Okay, people, you know the drill. Canned foods only, guys.
Sometimes you gotta live what you believe, open your arms, cause that's where it starts. Right here with you and with me. What the world needs now is love.
Generosity, pass it on.
A little help from up above. Faith to me.
A message from the Foundation for a Better Life.
You may say I'm a dreamer, but I'm not the only one. I hope someday you'll join us, and the world will live as one.
GHS-TV has a new website. You can now view any of our shows on our new media pages. Or check out the latest Wake Up Germantown or Red Devil postgame. As always, we're streaming live 24/7. Just visit ghstv.org today.
Welcome back. Dr. Jeff Mullins with Mid-South Family Medicine is here to tell us the good and the bad about cholesterol. So we talked a little bit about cholesterol and how that can be a contributing factor to heart disease. So tell us a little bit, why is that a contributing factor? What is it doing in your body?
Well, let's understand what cholesterol is. Cholesterol is basically is a lipid or a fatty type of molecule, and it's absolutely necessary for survival. Every cell in your body, the cell membrane that goes around that cell, is made of cholesterol. That's fine if that's all that's happening. Unfortunately, we have a lot of people that have very high levels of cholesterol. And where those levels are, depending on the type of cholesterol, are more important, and we focus more on that than back in the old days. We just looked at total cholesterol. Now we look at cholesterol ratios, and probably the biggest things we look at is HDL cholesterol and LDL cholesterol. And a way for a patient to remember which is which: HDL is good cholesterol, HDL, you want that to be higher, okay? LDL is the bad cholesterol, you want that to be lower, L for low. So quite frequently what we'll see, particularly in patients with other risk factors, is we'll see that the LDL is too high. Now, anything under 130 on the LDL is considered normal. But if you've already had a heart attack, or if you have if you're diabetic, remember I said that diabetes is the same risk as having already had a heart attack. Right. We typically want your LDL to be 100 or less. And in fact, some cardiologists who have diabetics who have already had a heart attack or some type of heart procedure want their LDLs to be as low as 70 sometimes. But for the average person walking and getting a checkup from their physician, anything less than 130 is probably okay, depending on risk factors, okay? HDL, the good cholesterol, we see that go down in people who smoke. Nicotine apparently lowers HDL. It also tends to go up with weight loss, and particularly with exercise. We have had some medication strategies to lower LDL and raise HDL, particularly with niacin, but at this point in time in history, niacin's kind of fallen out of favor for treatment. So now what we're really focusing on is getting that LDL down as low as possible. And there's two ways we do that. One is with a class of drugs called statins. A lot of people have heard of and seen commercials for Lipitor and Crestor and Zocor and these kind of medications. These are all statins. Statins work by inhibiting the liver from making cholesterol. Remember, the cholesterol is very necessary to have in your body. So whether you eat it or not, your liver is going to make it because you have this turnover of cells in your body. You need more cholesterol. The problem is, and this is theoretical, but the problem is, way back in history, a lot of our ancestors led kind of rough and tumble lives, and your ability to heal more rapidly, to replace cells more rapidly, probably meant you survived better. Well, flash forward to now, that's not as much of an issue, but your liver still makes lots of cholesterol, okay? And so some people genetically, their livers make too much. And that's why the statin drug classes are so important. Most people that have severe elevations of the cholesterol, they can't diet enough to get it down, okay? People with mild to moderate elevations, that's exactly what they should do, is undergo lifestyle modification. One of the things I'll often tell my patients, though, when it comes to their diet, is certainly reducing saturated fats. Beef, pork, and dairy products are probably some of the, and fried foods are some of the worst forms of that. But sugar plays a big role too. Sugar is the energy that most of the body uses, including the liver. And the more energy you give to the liver to make stuff, if you have a liver that's inclined to make more LDL cholesterol, it's going to make even more of it. When the Atkins diet came out, we were scared to death of people eating all this ground beef and bacon and such. We were going to see their cholesterols go sky high. Well, a lot of them, it actually dropped significantly because they were losing weight and their carb intake was so low that the liver didn't have this extra energy to make more LDL. Back to basics, the bottom line is to start with getting it measured, okay? And again, don't focus on the total cholesterol as much as on your good and bad cholesterol. If your bad cholesterol is slightly elevated, but genetically you have a very high good cholesterol, probably not a problem. If your LDL cholesterol is mild to moderately elevated and you have a genetically low HDL or you smoke, then that becomes a problem. So we look at the ratio between the bad and the good cholesterol.
Right, and the numbers are, we want our LDL to be?
On average, without risk, we generally want the LDL to be less than 130. If you have significant risk, like previous heart attack or diabetes, then we want less than 100. If you have a lot of risk, including having already had heart disease, we may want as low as 70.
Okay, and we should get that checked at least once a year.
Well, if unless you know you have a problem. Now, if you know you have a problem, your doctor will generally check it every 3 months or 6 months, particularly if they are trying to get your cholesterol lower with medication.
Okay, and then you mentioned that if diet and exercise, of course, would be your first route, and then your doctor would advise you of medication if that was
right. And of the big three that we treat, diabetes, hypertension, and high cholesterol, we kind of feel like we have more time to deal with the cholesterol. So it's always worthwhile to give a patient their shot at lowering their own cholesterol, and then if that doesn't work out well, then they're more likely to buy into the fact, well, I'm doing everything I can. Maybe it's time to talk about medication.
Right. The cholesterol in the body and how it relates to heart attacks, what is it doing within the body to cause?
Well, the best way to look at LDL cholesterol, the bad cholesterol, it is the building blocks for plaque, okay? So the higher the level of LDL, the longer the time, the more plaque you're going to build up. Now, there are processes in the body that damage the lining of the arteries, like hypertension and diabetes, that accelerate that process. And so a moderate elevation of LDL in a diabetic with hypertension may build up plaque faster than someone who is otherwise normal but just has high cholesterol. So our cholesterol values change as we get to know the patient better and see what other risks they have. But basically in the average person, no significant cardiovascular risk, having an LDL less than 130 with an HDL in the 40s or 50s is probably fine.
Okay. We mentioned hypertension, and that's what we're going to talk about next. So coming up, high blood pressure and how to control it. We'll be right back.
I see trees of green, red roses too. I see them bloom for me and you. And I think to myself, what a wonderful world.
GHS-TV has a new website. You can now view any of our shows on our new media pages. Or check out the latest Wake Up Germantown or Red Devil postgame. As always, we're streaming live 24/7. Just visit ghstv.org today.
Welcome back. Dr. Jeff Mullins with Mid-South Family Medicine is here to explain the dangers of high blood pressure, who's at risk, and what you can do to keep your blood pressure where it needs to be. So tell us a little bit about high blood pressure and how it can affect your body.
Sure. Hypertension or high blood pressure is basically a disease in which, if you look at an artery compared to a vein, an artery has a muscle wall, so it's a bigger, thicker type of blood vessel than a vein is. It's because the arteries, the tension of the wall changes as needs of the body, as the needs of the body are for it to increase the pressure or decrease the pressure. Veins pretty much just do what they do; they just carry blood back to the heart. So the term hypertension comes from the squeezing down of this muscle. Over time, this squeezing out of the muscle is just like going to the gym. If you lift weights, your biceps get bigger. If the we call it hypertrophy, and if the muscle wall gets thicker from chronically being too tight, then these people develop worsening hypertension. So one of the things I'll tell my patients is that good blood pressure feeds on good blood pressure, but bad blood pressure definitely feeds on bad blood pressure. And the longer your blood pressure goes untreated, the harder it is to treat and the more damage it does to your body. Ideally, we like to see blood pressure 120 over 80. Somewhere around 130 to 135 over 85, we start to call that prehypertensive. Anything 140 over 90 or higher is considered hypertensive. And then we further define it into stage 1 hypertension, stage 2 hypertension. And rather than throwing numbers out, I'll tell you right now, if you can control your blood pressure with 1 or 2 medications and do a really good job of it, you're probably a stage 1. If your provider is taking 3, 4, 5 medications to get your blood pressure control, to come under control, most likely you have stage 2 hypertension.
What are the symptoms that someone experiences when they have high blood pressure?
Well, some people will get dizzy, have headaches, visual changes. I've had people with very high blood pressure that actually had some chest pain because of how hard their heart was going to work. You got to realize if the heart's pumping and it's having to pump through an increasingly narrow arterial system, it has to work harder to get the work done, and so you can actually put strain on the heart from that. So some people have chest pain. But I think the people that are actually symptomatic with high blood pressure are the lucky ones. For years, they've called hypertension the silent killer. So most people feel just fine. And so really the only reason that you'll know you have high blood pressure is to have it checked.
Right. And how often should you get your blood pressure checked, do you
Well,
think?
it depends. If you actually have a high blood pressure problem and are on medication, you probably need to be checking it 3 or 4 times a week. Every day is fine, but at least 3 or 4 times a week. And for those hypertensive patients, it's a good idea to vary it up. Sometimes check it in the morning when you first get up. Sometimes check it when you first get home from work, because I'll tell you, as a doctor, if you show me your blood pressure readings and they're normal when you get up in the morning and they're just as normal when you get home after a long day at work, we got your blood pressure in pretty good control. So varying the timing a little bit is good too. For people who maybe are at risk for hypertension, you're a little overweight, runs in your family, African Americans, for example, some Hispanics we think are at higher risk for hypertension. It'd be a good idea for once or twice a week, when you go to a grocery store and they have a pharmacy with a blood pressure cuff there, walk over there and sit down, catch your breath a little bit, calm down, get your blood pressure checked. And doing that once or twice a week can at least give you a heads up as to whether you're starting to get readings. It very rarely occurs that you go from having normal blood pressure, what we call normal tensive, and then all of a sudden you're hypertensive. So what happens is over time you start to see more high readings interspersed with the normal readings, and then the high readings start to outnumber the normal readings. And if you notice that pattern, I usually tell my patients, if every other time you check your blood pressure it's elevated, it's time for us to talk.
So that's good to know. You mentioned a couple of groups that are more at risk for high blood pressure. What are those groups and who's at risk?
People who are obese are at risk. People have a strong family history. I've seen some very healthy people that work out and they eat right, but both mom and dad have significant hypertension, and they are hypertensive. They may not be as bad as mom and dad because of all the other things they're doing, but they're hypertensive. We know that African Americans have a higher risk, and like I said, some Hispanics seem to, and some Native Americans seem to have a higher risk for hypertension. Interesting about African Americans, though, for years when they were looking at the African American population trying to determine risk, they didn't separate out diet, okay? So they're looking at African Americans up north and they're saying, oh, we see the same risk in them as they are down south, okay? And what it turned out to be is they weren't eliminating diet for those people. So if you eat a Southern diet, I don't care whether you're African American, Hispanic, or white, because of the saturated fat and the salt that's in the Southern diet, that's gonna put you at risk for hypertension. So it's probably less being African American and more growing up in the South and loving that food. So.
Right, absolutely. What can we do to reduce our chances of developing high blood pressure? You mentioned diet.
Diet's a big thing. Basically, I usually focus on three things: decreasing salt intake, and as a corollary to that, increasing fluid intake, which helps you get rid of more salt. Decreasing your weight through decreasing the total number of calories you eat every day and increasing exercise. Losing about 20 pounds of weight over a 1 year period of time can drop your blood pressure 5 to 10 points on the upper and lower number. A walk 30 minutes 4 times a week can drop it another 10 to 12 points. Eliminating salt is different for different people. Some people are much more salt sensitive than others. Some people doesn't seem to make a difference. Other people makes a big difference. But in average, 2,000 milligrams of salt a day is enough for anybody. And getting more than that, you start to have more problems. Where we do see some sensitivity in the African American population is with sodium. They seem to be they're almost like sodium retentive. They seem to be very sensitive to retaining salt very easily. And so I encourage the young African Americans that I see, I just cringe when I see them eating a bag of potato chips and washing it down with Gatorade, for Pete's sake, and say, oh, more salt. So decreasing salt in your diet for an African American can be a big help for that population. But overall, moderating your salt intake, losing some weight, and exercising regularly are the three best ways to lower your own blood pressure, and can, if you start young, eliminate the need for medication altogether.
Absolutely. Well, it sounds like it all really ties together. It's all about healthy diet, exercise, and regular follow-ups with your
And luckily
physician.
Having good genes.
Yeah, that always helps.
That always helps.
That always helps and everything. Well, thank you so much for being with us today. There's some great information that I think will help a lot of people. Thank you. Well, that wraps up our show for today. I hope that living well will help you and your family lead healthy lives. Thank you for watching.